we actually had a beautiful result, from this case where there was a lot of lead movement. There was at least some contribution from the leads, and we got her down to trivial tricuspid regurgitation.
Hey, this is Matt Summers with MurmurMD, and I'm privileged to be joined by my partner and colleague, Dr. Josh Cohen. Dr. Josh Cohen is our structural heart imaging director, an advanced imager that trained at Cleveland Clinic and joined our practice in September of 2024. He and I do the vast majority of complex AV valve disease treatments here at Sentara, and have built from a tricuspid space quite a bit of experience with complex cases and common cases. And in this platform, the previous sort of focus or emphasis has been on aortic valve disease from a structural heart standpoint. But one thing that we're increasingly having more and more discussions about and decision points and collaborative discussions about is the complexity of tricuspid valve, which in TR in particular, which we now have repair and replacement options for. And so it's my privilege to introduce my incredible colleague, Dr. Cohen. Dr. Cohen, welcome.
Hi, everyone. How are you, Matt? Thanks for having me, and thanks to MurmurMD for having me. I'm excited to get into some tricuspid imaging. We'll get to the point now where we have some cases. We do a decent amount of complex stuff here too, and so we'll definitely show you that. I wanted to kind of start off with I say routine. I say that, but I say it with a lot of respect to tricuspid valves in the sense that I will tell you, I think I learn, and Matt and I say this to each other all the time, I learn something from every clip we do. I mean, really, like the things that seem the most simple sometimes end up being the most complex, and vice versa. And even some of these lead cases that we'll show you, I would walk in maybe as the pessimist and say, I'm not sure, like, should we clip this? Should we not? I'm worried about this lead. And we walked out with beautiful results. And so some of that experience kind of early in my career has shaped the way I approach some of this as well. So we'll start with a routine clip for one.
I would just tell you too, I think what I've learned from this too, so first looking back at the original Triluminate cases that we were doing with generation 3 and some of the difficulty we had doing it in intent to clip views and TRICOM views, it's remarkable that we got the results that we did. And so considering that, if we could repeat that trial and that early experience with what we're doing now and the precision that we have now, certainly, yeah, it's like CTOs, if, getting very, very good at the complex ones, make routine PCI all the easier. I do think that there's an escalation in sort of your capabilities and the kind of cases that you're willing to take on when you start at the standpoint of this is an imaging driven procedure. I tell every single patient that you're the eyes and I'm the hands, and it's a two-person operation, because it's very much true. If you don't have a good imager that's also done the pre-imaging, that's facile in all of these, your capabilities of cases that you can actually successfully embark on are a magnitude or order of magnitude different. And so what we're able to do now, what we're willing to take on now, what we're getting results on now is dramatically different than 6 months ago and 6 months before that in the trials. So I can't reiterate enough just from my position how, yeah, the routine clips would have been tough clips even a year ago, but we're getting better and better at these every single time. And it's because of really the fact that this is a very collaborative procedure and is really dependent on two people working at high levels to get a good result.
Yeah, I would echo that, pun intended. But I think, working with Matt and one of our other partners, Parth, I think the way we were trained, you guys are not heavily reliant, but the understanding of fluoroscopy angles at the same time as echo, and maybe we'll talk a little bit about that, or you can, shed some light on that in some of these cases. I think, often you guys know as much as I do, right? I'm trying to get you the best picture, but you guys know as much as I do in terms of the imaging. And so when you're on the same page about what we're actually doing, typically you're doing things that I'm ready to tell you about before you're doing them. And I think that's a powerful thing as part of a team, right? To be successful in this. So I think it really is important for the interventionalist to really understand the imaging component as well, and even I would argue that the imager should really understand kind of all aspects of the case too. And I have a fluoro screen kind of right next to me when we're doing it as well, so I can kind of correlate in my mind. Um, all right, with that, let's start with case one. So this is again our quote unquote routine clip. So 88 persistent atrial fibrillation, symptomatic bradycardia. uh, had a leadless pacemaker, a ventricular, a veer HFpEF, and severe symptomatic degenerative tricuspid regurgitation. You can kind of see there's maybe like a small little cord or degenerative strand on that valve. Um, you see a transgastric here, kind of leaks across the whole valve here. Um, and big kind of floppy looking valve. 3D MPR, kind of nice images. The things I would point out here. Um, you can, if you look closely kind of through this 3D image, you see this thing flopping around under the valve and towards the septal leaflet or just under the septal leaflet. This is that a veer that was placed. I would make the comment that I think as we're placing more and more of these devices, or as our EP colleagues are placing more and more of these devices, um, again, I'm not saying all these should be driven by TE, but I do think there has to be some consideration for what the future may look like and what therapies will be able to be offered, because this lead is super close to that septal leaflet, and then your TR here. And so again, kind of a wide jet, mostly kind of in the center. And so how do we approach this? What was our procedural plan going in? I think you had asked me earlier, like, what did we learn kind of from the beginning to now? I think, um, you know, starting off, I think when you talk about degenerative TR, if there's something focal, often you will target that focal jet. It's kind of a, I think, natural instinct to say there's a leak here, I should clip that, or I should target that. Um, I think with our experience, we've really kind of realized that when you start kind of near the AS commissure or central AS or something like that, you really do have an annuloplasty effect. And it really can alter the anatomy of the valve and the leak significantly, even if you're not targeting that leak uh, right at the point of it. And so our procedural plan, I was just kind of showing this in diastole and systole to show that this really kind of was a mostly a two leaflet looking valve. And so our procedural plan was to just kind of start near the AS and clip back and kind of see how we did. And so we start here. We're above the valve. We're towards the anterior part of the valve again to orient you. Aortic valve here, septal, anterior, posterior, or if we'll say septal and lateral because we think it's kind of a two leaflet valve. We go under the valve. We see the leaflets inside the clip, right? Kind of what you're looking for is in the base of the clip before you let those down. Again, as I showed you, I'm aligned reasonably well with that clip. So I see the arms perfectly well, and I see where the leaflets are interacting with those arms. We come down, we see both leaflets in the clip. Again, one of the, I know this is a smaller box, but this is kind of the point I was making before is I took a much smaller box here. You can see that the spatial and temporal resolution is actually much higher. And you can see you got like a really nice tissue bridge there, but I am in no way imaging the entire valve, right? And so I think it's just important, that that's what we're doing. If you look at the next picture here, again, we just kind of go to other views to confirm. We're in the transgastric. We see the leaflets coming in our blue box down here, and we have a nice tissue bridge. So we let that one go. Clip looks fine on there. There's a little bit of leak posterior. As I said, it was a reasonably wide origin in a degenerative pathology. And so we planned for our second clip. We maneuvered that clip right over kind of where our target was, right where that kind of second leak was. We come below the valve, again, kind of being able to understand how close are we to that clip, what's our orientation kind of all at the same time. We see our leaflets inside our grippers, or sorry, inside bouncing on the arms of the clip. We come down, we grasp, we're still attached here, but obviously this is a really nice result here with the strategy that we planned out, for. And so I would argue this was a pretty straightforward clip. We put two clips on. We went maybe a little bit more posterior on the valve than we had planned with that second clip. But kind of trivial looking residual TR. And that was that's the first kind of, again, quote unquote routine case. The Avere added a little bit of complexity in the sense that we wanted to avoid that. It was kind of right under the septal leaflet. But because we were able to see it, we were able to avoid it. You can kind of see in our green box here, that Avere is just under that septal leaflet, but not totally interacting with those clips. Anything else to add to that one, Matt?
No, I think it's a beautiful demonstration, start to finish, of how you use 3D MPR. And again, just as as an operator, I enjoy how iterative these procedures are. We go in with a plan as far as clip strategy, targeting the leak, targeting the annulus. I think most of the time we're starting in the AS commissure, but oftentimes the valve, as you mentioned, changes over the course of the procedure. And so the ability to adapt and actually get as precise as saying, we have enough room for an XT, don't have enough room for an XTW. Those kind of things are make this very, very rewarding as far as strategy and iterative sort of procedural process based on really good imaging like this. But it also, I think, highlights, I think that there's a misconception that TriClip is just a TR reducing therapy. I mean, there's very, very, very little TR left in the vast majority of these cases. I think in our 122, I was just looking at this, we have a 2.9 grade reduction, starting from some pretty sick patients. But a pretty substantial reduction in TR. You can eliminate TR in a lot of these cases if you follow a procedural, not algorithm, but approach as far as imaging intensive, and then adapting your clip strategy, much like you would a CTO when you change strategies quickly and based on what you're encountering in the procedure.
Awesome. So case two, we're gonna kind of start to move into the more complex stuff. So, example of leads, what we do with these ones, we decided to move them and then clip. This was a 79 79-year-old with mitral valve disease due to functional mitral regurgitation, who had a prior MitraClip, I think a couple of years before, with two XTWs. We had seen her previously where we fixed the mitral that had severe residual leak with a clip in between, and had a really nice result. You can kind of just see a typical 3D image there. The mitral, a little bit of a gradient, 4 to 5 or so, at a heart rate at 80, but was doing well from that perspective. Had sick sinus syndrome, paroxysmal AF, left bundle lead, had CRT more recently, and then progressive symptomatic TR.
This is what we're seeing in practice too, right? It's like the penalty for getting a good result is that another thing crops up. Patients survive long enough to get something else. That's the hallmark of TAVR, is that now patients have calcific mitral valve disease and TR and things like that we have to address. But with that last case, they were referred for InterClip MR after about 2.5 year good result for really tough ventricular functional MR. We did that, left with another clip with a gradient of 4, and now 2 years later we're also approaching the tricuspid valve.
Yeah, and so you can see here is there's severe TR, mid-esophageal image quality is okay. There's a lot of kind of thickness around these echo densities that are leads. You can essentially see the leads kind of moving with the valves. When you go to the transgastric MPR, what you see is there's a ton of mobility to this lead. And so, I would point out here that in our short axis, in our green box, this is the lead. And with systole, it moves halfway across the valve. And you can see it definitely kind of restricts the motion of that septal leaflet kind of here in our blue box. And this is an ICD lead. It's a thick lead. The other thing too that you'll notice in the actual 3D image, and you'll see kind of part of in this red box, is the CS lead is very redundant as well. It probably doesn't affect the TR, but does affect how you think about getting to this valve and making sure you're not going to interact with it when you go to clip it. And so again, you can kind of see this posterior movement. Again, this is our AP trajectory or AP plane here, kind of in a long axis in the stomach. It moves very posterior with each beat. And not that, on fluoro, we can see that as well, right? So you can see with each beat, with each systolic beat, that this ICD lead moves a ton.
You can almost see that CS lead sort of wrapping at the annulus and hitting with each contraction the annulus. So it absolutely affects deploying the clips, but the dramatic movement that systolic posterior movement of the ICD lead was really what stood out on that fluoro image.
So, what we decided to do in this case, let me go back, sorry, is Dr. Summers actually took an Agilis catheter and essentially kind of pulled some of the slack out of those leads. And what you'll notice is that they're not moving a ton anymore. And then, kind of more dramatic, in my opinion at least, is on echo. You can really kind of see um, all this happening. So I'm going to let all these play, and now we'll kind of go through one by one. This is the original image, right? You see we labeled the ICD lead and the CS lead, and it's just a ton of movement, right? Posterior movement during systole. When he kind of got onto the leads, there's less movement, right? Just kind of having them corralled. And then when he actually moved them posteriorly, you really see in a nice confirmatory way, this lead has now kind of been moved all the way towards the posterior aspect of the valve. And no longer do we really see that CS lead kind of hovering above the valve and in the way. And what this does too is it kind of pulls that lead away from the septal leaflet at the anterior portion of the valve and allows us to have a target to clip there. And so that's kind of exactly what we did. We felt like our transgastric imaging was kind of our highest quality imaging here. And so we actually did this all from the transgastric views. And so you see us above the valve here in our blue box, you see the SIP clip kind of coming into view. We have our short axis view, and then we have our AP view. And in the 3D, you can see that the lead has been pulled back right here where my cursor is, and then our arm orientation and our position. And so then we go under the valve, right? You now see us under the valve with the clip. We're kind of in the central AS, central portion of the valve, right? But anterior and septal. Here, really nice demonstration where you see the lead, you see our arm orientation, you can see the gripper line and everything here with the arms, with the grippers down, and leaflets inside. And then we start closing, and it's really kind of amazing to see this all happen, right? So we're starting to close that clip, and we do that here, and you kind of see a really nice clip as it's closing, it's kind of corralling everything, lead staying in place, and the valve really starts to kind of change shape and come together.
Incredible imaging in that. I mean, just look at what we can see and the relation of the structure.
Yeah, this was a fun one.
Unbelievable.
And so here again, clip is closing more, clip is closed. And so again, you see the lead right kind of behind that. Valve looks like it's kind of coapting in a reasonable way. And so then we're going to assess this, decide if we want to keep it and decide if we like the result. And hard not to like this result. Obviously the leaflets are in the clip there. They're nice and taut. Lead is kind of we've moved that kind of behind and kept it there. And this was our result. We actually had a beautiful result, from this case where there was a lot of lead movement. There was at least some contribution from the leads. And we got her down to, trivial tricuspid regurgitation. And then, again, just showing some other views of final results here.
The other thing that helped,
one more view of what happens with the fluoro.
yeah, there's a lot of clips there.
A lot of clips, a lot of therapies, devices, but a really good result for this patient. So again, you see kind of this hinge point, lots of movement on this lead. Really not much here when we let go with the Agilis.
That's cool. The moving the leads also helps with the imaging, I think, too, right? It pulled
absolutely.
You could really fine tune those transgastric images.
Yeah, and it kind of allowed us to have a really nice spot, both imaging wise and on the valve wise, to understand where we could clip the valve and kind of get the most bang for our buck. Another case, case 3, so kind of laminar TR and another lead. This one's interesting for multiple reasons. 73-year-old female. We thought lead related TR. This can be really complex in terms of understanding if the lead is the primary cause, if it's part of it, and it it tends to drive decisions sometimes, right? If you think you're not going to be able to clip around it, or corral the leads or something like that, you may have to remove them, or you may have to pick a different therapy. And so upfront evaluation of this, it could be its own talk, but I think that's a really important thing that we spend a lot of time on trying to understand the lead contribution. And so again, really severe TR here. This is kind of a classic teaching, but you see a brief jet. This is rapid equalization of pressures, and I'll prove that to you. But there's almost laminar TR. You get a really dense triangular Doppler profile, which fits with this. Um, and so what you notice here in a transgastric, I really couldn't get this to come together much better. These leaflets are very far away from each other, right? This is a massive coaptation gap. You can just kind of see this brief color jet. This is, torrential TR, and you kind of see there's maybe multiple leads here. I'll show you some other images here. And so when I saw this transgastric, I realized it's not the highest quality, but if you follow me in the green box here, I thought there were 3 leads. I thought there was 1 lead here, 1 lead here, and 1 lead at the posterior aspect. When you look at all your other views, you realize that there's one of these leads is actually coming all the way down in the right ventricle and then curling back up. And so at that point, I went back and looked at kind of our original testing, just a plain film of the chest. Obviously here again is the severe torrential TR. And the question at the top begs the question, right? Is it always the ventricular lead? Most of the time it is, but not in this case. And so what you see is that the atrial lead actually swings all the way down into the right ventricle and comes back up. And that's what we were seeing. And that's kind of what you see in echo here. You see the ventricular lead here in 3D, and then you see this atrial lead come down, swing around, and back up. And, at least my thought was that I think it was probably propping the subvalvular apparatus open. The sad part about this is I don't think this was recognized for many years. And so, I think by this time, as with other lead cases too, when you have a very early lead that's causing TR, oftentimes removal may fix that. Once you're, past about a year or so, I think it's not often that we see people remove leads and just have, TR be gone. And so we figured we would have to make a plan for this. And so, we did. Again, we implanted a dual chamber leadless device. And when I say we, I mean our EP colleagues. What's nice here is we have a really, really good group of EP docs and really talented lead management program. And so, we can take things out. We can have it. What I really like the most is we can have their opinion on whether or not we should take things out. The last thing I want to do when I see someone in clinic is convert a very safe TriClip procedure to a less safe or more morbid, procedure that requires cardiac surgical backup, or where we could tear a valve. And so we've kind of gone back and forth on how aggressive we are about, lead removal versus clipping around leads or something like that. Here that this lead, came out, and you can see the implanted device there. This is kind of post lead extraction. So again, that TR did not get better. That valve is still not coming together. I guess it can, could beg the question of like, were we right about it being lead associated or not? It's tough for me to know, what's scarred down below the valve, but you can see that leadless device kind of right down the barrel of this valve when you're looking on FOSS here. Super severe TR. You see that on the ICE imaging as well. So we have T, 3D T, and then our ICE images. And then, so what did we do, right? So our procedural plan was, I made a little joke here. I'm kind of putting clips, like, what do we do for this? This whole thing leaks. There are big gaps. Should we have, gone the other way? Should we have done TTVR? I think no one would fault you for that. But, so our thought was, let's try and pull a little bit of the septal leaflet off. Let's try and get a good annuloplasty effect at the AS commissure, and let's see what we're left with. And so that's exactly what we did. We kind of came down towards the anterior portion of the valve. The additional thing about anatomy that I think is helpful for this valve, which is why I think we push towards this, is it's also a bileaflet valve. And so when you have 2 leaflets, I think you get much more bang for your buck with clips kind of stacking, anterior to posterior than having to understand what the anatomy does when you have a true, AP commissure or AP canyon. So we get under the valve. Again, imaging's a little grainy here, but you can see the leaflets in the base of the clip. We close that clip. Leaflets are nice and taut. We're right kind of adjacent, right in the AS commissure. We look in transgastric. We kind of confirm that. Do we like the way it came in? And what I would say here is we've converted, laminar torrential TR to severe TR. There's definitely still a lot of TR. There's definitely big coaptation gaps. They're not quite as big, but this was, I think, promising um, for us. And so we then decided to come in with a second clip just behind that first one, lined it up the same way we always do, came below the valve. Again, I'm aligned with our arms here, and so I can see really nicely at our green box, green line through the arms, green box. I can see the leaflets really nicely. We pull that together again, kind of really nice result. Everything comes in. You see how this actually looks like a valve now, right? And there is almost no leak left. So we laugh and we say washing jets. This is a really nice result, especially given what we started with. Um, and so this is a case we were really proud of, right? This lady went through a lot. She, had to have a lead extraction, had really torrential TR, was suffering with symptoms quite a bit, and then we were able to get her a really nice result with this.
She's a lady that this is the other thing that's dramatic to me in clinic is how many patients come in with cardiac cachexia from undiagnosed degenerative TR. It just hasn't had therapeutic options in the past.
Yeah,
This obviously was a combination, but it was bileaflet valve, and so we were pretty worried about her frailty going in with all of this, but it was absolutely necessary given the severity of her symptoms. And like
yeah,
you said earlier, it's a safe procedure. In the vast majority of scenarios, we're able to reconstruct this valve.
agreed. And then just kind of showing, we used ice in this. Did we need it? I think we could argue maybe we didn't, right? We had really good TE imaging. We were able to see images were a little grainy, right? But again, use your tools if you have them. And so able to see kind of leaflet insertion here. We reconstruct in 3D. You see it well. This is after that first clip. There's TR, but it's not anything like it was before. Again, we were encouraged by that, especially because it's kind of in this one place. We go back with a second clip, get a really good grasp, and have again trivial TR even by ice there. So use all your tools. You saw that we went and confirmed in the transgastric, right? We're up and back. The last thing we want to do is not be sure, and sometimes that happens. But when that happens, we've exhausted all of our other tools, and then we know we're not going to see it better in any way. And then just showing kind of what the fluoro images look like: first clip, second clip, and our result there.
I know most people have adopted this practice, but I think swinging over to take the parallax out of your AV groove for both mitral and tricuspids, but particularly the tricuspids, it is extremely helpful, especially if you're doing multiple clips. You can really assess subtle changes in your orientation with advancement of the clip as you get more knobs uh, on to change your trajectory of position. It also, the clip wants to transmit that torque later. And so you tend to get a lot of spins and you don't want to make a ton of movements under the valve, of course. And so lining things up in this way is really key from an operator standpoint too, and making sure you understand the 3D NPR, the 3D anatomy in the context of a two-dimensional fluoro image.
Agreed. And our last case here. So again, there's maybe a little bit of a lead theme or something. I don't think that was the purpose, but just to kind of demonstrate the imaging and the complexity. This was an acute flail during an extraction. So again, it kind of goes back to that. Do you send someone, right? Do you send someone? And this was an extraction for lead related issues that were not valve related. These were a failed lead. Um, but able to deal with this on the other side, when our EP colleagues call us, especially to support, a really good extraction program, because this is bound to happen. And so this was a 67-year-old male, diabetes, hyperlipidemia, a reasonably healthy guy, had a pacemaker placed many years ago due to syncope and carotid hypersensitivity. He had lead failure, and so he had a lead extraction. Unfortunately, this was complicated by a torn tricuspid leaflet or flail leaflet. There's some question of like, did the AS commissure, get avulsed? Is it a mostly anterior flail? Um, and then, what were we going to do for this gentleman? And so, I think the plan here, given normal RV function and the fact that we were worried about getting a really durable result with a flail and, maybe, some sort of version of the AS commissure, we decided to pursue TTVR. And so, we screened him. Um, this image kind of shows this was, I think, during the extraction. You see this flail leaflet. There may be very well maybe part of a pat muscle on there. Um, there's a significant Chiari network here as well. And I don't think we totally appreciate the extent of that TR. You go into MPR, you see it's really kind of involving, maybe the AS commissure, certainly this kind of anterior portion of the anterior leaflet. And then you see it's that jet is fairly broad in origin, and really kind of originates exactly where that pathology is. And so, this was a multidisciplinary effort where what we did was we screened with CT, and then we actually brought this patient back for a leadless implantation under TE guidance, um, with a subsequent TTVR. With Evoke, the issue here is you do have to have room between the device, the leadless device, and the valve you're going to place, the annulus. And so this was actually one of the harder parts of the case. Is, we place this in multiple different areas, and then what we're doing with MPR is measuring. Are we, I think what companies will tell you is you have to be like above 1.8 or so. They'd like you above 2 as for margin of error, but so we were about 2 after multiple attempts. Sometimes we try and go up towards the RVOT. I think, and I wouldn't speak as an EP, but I think sometimes that's um, a less good place for them to place it, but maybe more fitting for us in the valve, on the valve side. But we ended up getting about 2 centimeters from the annulus, and so we felt good about that. Here was just some kind of basic CT measure, C size for a 44. The things that we were concerned about were appropriately looked at. The big question was, is it less than a third of the annulus that's involved with this flail? And then the things we also were concerned about is this guy really hadn't remodeled, right? This was an acute issue. And so RA height was a question. We ended up going from the left, and we're able to get this done. Showing here just in 3D some of the pre-measurements we make. uh, you know, um, AS measurements, and then septolateral measurements as well. AP dimensions, sorry, and septolateral dimensions, and then a perimeter. And again, just kind of demonstrating some of the complexity here. The AVIR is here, or the leadless is here. The flail is here, maybe with some pat muscle there, and then a big QR network, which again isn't too much of an issue, but like when you're bringing big things into the right side of the heart, you could certainly get tangled in that. And then that with the flail is maybe not a great combination. So just quick points of this. So wire position is a big issue here. You want to make sure that you're behind the anterior pat muscle. We also want to make sure we were out of the way of the leadless device. You see that nicely here. This is again a long axis in the stomach. You see that flail kind of at the anterior portion of the valve. You see a little bit of that Chiari network coming in. You see the wire, and you see the AVIR. Then you want to look for the capsule gap. What you want to make sure is that you're not interacting with the pat muscles, but you're also below the valve. You see that capsule gap nicely pointed out with the yellow. That correlates to this fluoro image. And then similarly, a fluoro image of where that wire is placed in relation to the device. So then, really, and sorry, these are a little out of order, but really what this ends up being is you start to slowly deploy the arms of this device, and then they start to curl up. And basically about halfway through that, what you're doing is you're making sure that you're in position to capture all these leaflets. And so this is a pretty imaging, intense procedure. And what you do is, kind of in this area here, where you see all these arms, what you want to make sure is that, you'll kind of call out in the room, hey, we're looking at green box, left side of the screen, or something like that. It doesn't really matter which side, right? You just have to all be on the same page. And you want to make sure that when you put this green line over each one of these dots here, which are essentially these arms, you want to make sure that the leaflet is up and over and capture. And we're kind of calling that out as a procedure, or during the procedure. And then each stage of the way, we're kind of coming up closer to the annulus, making sure that we have capture, and then really just working on trajectory to make sure that we're going to abut the annulus both septolaterally and AP. And then you essentially deploy the device, and you kind of see the fluoro correlates here of what those arms are doing, and kind of the relation as well to the AVIR. And it's really kind of nicely positioned to not interact with that. And so this is really kind of high fidelity imaging to guide, really, in my opinion, about as complex as it gets. Um, Then you'll see we start to deploy the ventricular portion of the valve or expand the ventricular portion of the valve. Similar here, more expansion, and then full expansion here.
Look at the fluoro, the proximity, how close we are to that Avere, and how precise it had to be placed by Dr. Keel. It's
Absolutely,
pretty incredible that we can guide. I think that's an important highlight of this too, is that you can guide their reimplantation very precisely with TE to make this feasible.
absolutely. And so then, we have a nice, working tricuspid valve. There's a trivial amount of, valvular leak there. You can see, I think, some of that Chiari left near that valve. Really nice ice images here as well. And then just showing 3D images on ice as well. No paravalvular leak, valves functioning well. And that gentleman did really well. This is me and Dr. Summers. We had the privilege to go to Sao Paulo and Rio and proctor their first TriClips, and we've been involved in some of the tricuspid TriClip 101 training as well as some of the advanced imaging training. And it's absolutely a privilege to be part of the educational rollout and sitting next to some of my mentors with very much imposter syndrome to be involved in some of these conversations. But I really appreciate the offer to come here and speak about the stuff that we're really passionate about here.
Yeah, well, really appreciate you doing this as well. I think from a standpoint of these therapies getting rolled out, the way that the results are safeguarded with all tricuspid therapies is really an attention to detail that you garner from advanced imaging. And as a place that does the common and the complex and in both therapies, and be involved in most of the trials, I think one of the things that I've taken away, not as an imager, but as someone that is heavily reliant on imaging, is that the feasibility of these cases is highly dependent on understanding the fundamental things that you went through, which is that you have to understand anatomy, you have to understand to the level where you can fill in no pun intended, the gaps as far as what you're seeing and what you're not seeing, using ice, using a lot of different modes, a lot of different understanding of views and how to optimize those views. I don't think anyone does it better when we're at these courses, and your counterparts are there. I do think that there's a different level of precision with a lot of this imaging, and kudos to you, and really appreciate you going through all the details. Hopefully,
Of course.
other imagers on this platform, even interventionalists like myself, who learn a lot from the descriptions of this anatomy by imagers that are looking at it day in and day out, benefits other folks at other programs.
Awesome.
Awesome. Thanks.
Thank you.